Welcome, everyone. We're going to get started. Thank you for joining this session, How to Build a Dream Team, sponsored by Ironwood. I'm going to pass it over to Dr. Marion Winkler.
Thank you. Good afternoon, everyone. Well, it's really my pleasure to tell you we're going to have a panel discussion this afternoon and talk about how to build a dream team. And before I go through a little bit about what our objectives are and what we hope to cover, I want to ask each of the panelists to introduce themselves. I'll start first and let you know my name's Marion Winkler. I have been involved in the management of adult TPN in a hospital setting and in home care. So we follow our patients through the hospital all the way to home. And with that brings a long time experience and expertise in short bowel syndrome and intestinal failure. So as each person introduces themselves, they're going to give you a little bit about their, why they're here also today. So Bethany.
Thank you, Marion. Hi, I'm Bethany Johnson. I currently live in Southern California. I was born with pseudo-obstruction syndrome and global dysmotility. I currently live with ultra short bowel syndrome. I'm an architect, a program manager. I'm on the board of Intestinal Rehab and Transplant Unwrapped. We have a booth out there. Come see us. Thank you. Where was I at? Oh, and I enjoy hiking and biking. I am 100% dependent on PN and just completed my second half marathon, which I thought I would never do. I'm here today because when I first started living with short bowel syndrome, I did not know that was the diagnosis. And I'm hoping that I can share a little bit with you today about what it can be like to live with SBS. Thank you for having me. Thank you for Ironwood as well. Dave?
Thanks, Marion. My name is David Vermette, and I've been a Crohn's patient since 1978. Due to an emergency surgery in 1995, I've been on TPN for almost 30 years now, 30 years coming up in November. I am still able to eat and drink, so TPN is just an assistance for my nutritional therapy. And I currently am a sales representative for a digital printing company. I also was an illustrator in the advertising studios in Detroit and Cincinnati. And I am a former consumer advocate as well.
Dr. Adams?
My name's Dawn Adams. I am an adult gastroenterologist at Vanderbilt in Nashville, Tennessee. I'm medical director for the Center for Human Nutrition, and I run our home intestinal failure program, which is about 150 patients on home parenteral nutrition. We also manage patients that have short bowel syndrome, enteral needs, and various other needs related to intestinal failure.
So I think it's important that you all know that we're just meeting each other ourselves, except for the preparation for today. We haven't had involvement with each other, and everyone's going to share their perspective of putting together the dream team. So with that, our learning objectives today are to talk about what a dream team for short bowel syndrome is and other serious intestinal disorders, and let you know they can look very different depending on if you're in an academic center or in the community or have pieced it all together. We're going to talk about how to build a team if you are in a place where there is not access to an intestinal rehab program or center of excellence, or because of your own life trajectory have moved or have had to find a new team. We'll talk also about what to do when you hit a crisis and you require specialized care, because we know that the need for different types of care changes as one grows, as one ages, as one moves along in their own unique journey. And we want to provide some important details and tips about how you can help share your health condition. And finally, we want to talk about using your network to find expert care, like the peer-to-peer we talked about this morning, professional directories, organizations like Oley, and others. So why is the expert team important, and what do we mean by that? Well, specialized care and interdisciplinary and multidisciplinary teams may look very different. Teams may have different clinicians on them, different organizational structures, maybe different requirements for referrals and consultations, but what they all have in common is you as the center of the team. Furthermore, every patient or family's needs for expert and specialized care may be different, as I mentioned, and may change throughout your own individual health journey. And we know that the need for this expert care is because of the challenges that are faced with short bowel syndrome and intestinal failure. And there's dependency on the IV nutrition or IV hydration or enteral nutrition or oral nutrition and oral rehydration therapy. That there's always challenges to deal with, including malabsorption and dehydration and weight loss, that there could be complications and repeat hospitalizations. And those are medical things that we tend to focus on, but we also recognize the importance of the psychosocial and coping aspects, social lives and relationships, mental health issues and quality of life issues. And all of this put together is why a knowledgeable healthcare team is so important. The reality in us is that most people are treated outside of these academic centers in smaller community hospitals and where you might not have knowledge and expertise. So Dr. Adams, can you tell us a little bit about how your team works to provide your best care for patients?
Yes, I'm very lucky that I have a dream team. So my team consists of physicians. I have myself and another gastroenterologist. We have advanced practice providers. We have amazing pharmacists and dietitians who have been in the field of nutrition support for many years. We have nurses who are trained in line care and a case manager. One thing my dream team is lacking and was commented on is a mental health provider, which I think is essential, and I would really love to make part of our team. Another thing that we have is, it's not a person, but a concept, communication. So I think my team is really great at communicating with, of course, the patient, but also all the other complexities that we need to communicate with in the management of intestinal failure. So constant communication, for example, with the home infusion company, with the home care company. We're constantly communicating with the surgeons, sometimes the primary care doctors. The patient's admitted to another hospital, we're communicating with the hospitalist there when needed. So I think that's, whether or not you have all those individuals on a team, is a really important part of the team to make sure that everyone is communicating.
Thank you. Bethany, you've said a couple of times that you've had to cobble together your experts from all over the world. So can you share a little bit about your journey in finding a dream team and what you experienced along the way?
Sure. Yes, in my experience, I was at major medical centers, I was at academic centers, and I still could not construct the full team that I wanted in one of those large places. And so I got good at networking in the medical community and trying to find the right team. And I found that it's okay to go visit a doctor, have your appointment, and decide, nope, not the one for me, and go to the next one on the list and the next one on the list until I had the correct team. It's interesting because even, at one point in time I needed to find a really good acupuncturist for the muscular pain that I was experiencing and putting that all together. And so I found that through asking my other practitioners and my other doctors that I trusted where to find the piece that I was trying to fit in my team was really helpful. The Oley community and Facebook groups and community organizations were really great in that as well. For me, my dream team has to respect me as an autonomous person. And they have to be my advocates and my cheerleaders and my champions. because I can't do it all. And so they have to have those qualities to be on my dream team.
Great. Dave, can you talk about your experience with that, how you set goals with your team, and how you work together with your team?
Sure. In my situation, when I had my surgery, it was emergency surgery from a complete intestinal blockage. So I woke up 7 days later from a medically induced coma, and the surgeon that basically saved my life, he had experience with TPN, and so he initially took over my TPN. I think the one thing that I would stress is to educate yourself, whether you're a caregiver or you're the actual consumer or patient yourself. And the best way to do it is to ask questions. But when my surgeon took over the TPN, he knew how serious I was about taking care of myself and having the best possible health outcome. And so he gave me respect because I asked good questions, but he knew I was on top of it. So I had my surgeon in place, my gastroenterologist in place, and I wanted to make sure that we were all in communication and we were all on the same page when decisions were made. So my suggestion is it's great. You really need to be the quarterback of your team and choose wisely as far as who physicians and surgeons and the whole part that make up your team, nutritionists, etc.
So both of you have talked about the need for various team members at different points, and Bethany, you mentioned a little bit about using some organizations and networks. Can you both talk a little bit more about trying to explore and find where these experts are and whether you have a match?
Do you want to go first? Okay. It's interesting because as you grow and change as a person, your team also needs to grow and change with you. And one of the things that I tell people is it's okay sometimes to acknowledge that you have been a great provider for me for the last 10 years, and now I need X, Y, Z. And I'm still going to come back to you. I have some primary care doctors. When I'm in town, I still call. And if I needed them, they're there. But you have to acknowledge that. I think a lot of times it's scary and it's hard to think about changing. Or I recently moved from halfway across the country and had to rebuild my team. It's still not quite there. My teams have often been constructed of a local team that has to be there when stuff hits the fan. But then my experts are in different places all over the country, depending on what I needed at that point in time. And so that's been a really hard lesson that I had to learn, because change is hard and it's scary, but sometimes that's really what you have to do. And I do think having a rare disease like pseudo-obstruction or short bowel syndrome, unfortunately, I just have to know I have to travel. And I plan for those yearly or every 6-month appointments. I have a savings account, and so much money out of every paycheck goes there so that I can afford to do that, because insurance doesn't cover that travel. And so it's just something that I've had to do, but that has helped me.
So, say that question one more time again.
So I wanted to know, how you actually sought out expert care and some of the challenges surrounding that.
Thanks, Marion. So my surgery I was 33 years old, and I was very active prior to that surgery. And so as I was laying in the hospital, I knew that it took me a little while to kind of grasp the situation that I was in. Becoming a short bowel patient, I mean, that is a life-changing event where when you need this lifelong, you have to kind of adapt to the situation once the reality hits you. And so I always knew that I wanted to stay active, and I wanted to stay full-time employed. So knowing that, I tried to seek out the physicians and the experts that would help me maintain that lifestyle as best I possibly could. So I was looking for the experts that could provide strong information for me and understand my situation better.
Yeah, and so we've heard that there are challenges in finding these, the expert care that you need at various points, the insurance hurdles, the finances, the distance to travel. So Dr. Adams, in your practice, some of your patients come from your institution and are already in the nice setting of having interdisciplinary expert care, but I imagine you also have patients who need second opinions or referrals, or you receive people inquiring if they can participate in your program. Can you talk about some of that and your advice?
Yeah, sometimes those patients that come from outside actually can be the most rewarding because they, I find, have often been misguided. Sometimes they come to me saying, my doctor, my surgeon told me I was going to die, I can't live on this. I'm still on 24-hour PN with no breaks, just crazy formulations. So I really enjoy helping those patients to understand a little bit more about their disease process. And I think through our multidisciplinary team approach, they get to meet with me to give them the medical opinion. They get to sit down with our pharmacist, talk more about the concept of the infusion. They get to meet with our dietitian to go over the diet, meet with our nurse to review line care. And I think really providing that whole picture and describing to the patient that this is a journey and we're going to follow you through it and there's going to be setbacks, but you can live a very long and rewarding life with intestinal failure, and continuing to communicate with healthcare providers and keeping up with your health is really important. I would say that, just a comment someone made during one of the earlier sessions with difficulties with records and communication, just as a little plug, it's really helpful as yourself as your own advocate, if you can, to keep a copy of your medical records. I know it seems like in this day and age, we should all just be able to turn on a computer and look at every hospital and download these records. And maybe one day we'll get there, but we're not quite there yet. So I think something that can be really helpful is if you can keep, a file of what's happened to you, whether that's digital or old-fashioned paper, and bring that and have those discussions. I also really liked earlier the care plan, because even if you have your dream team, you might be traveling and something happens and you get an infection and you're not near your dream team. And so having a care plan that you can take around with you and have with you in case something happens. I really liked that idea that was brought up earlier, and we do try to talk to our patients about that.
Well, I think each of our panelists have a unique perspective on this, so I'll ask them all, how do they share their medical condition and tell their story when you're moving around and seeing multiple providers? Bethany?
Yeah, so the suggestion about this plan of care and bringing that, I like that a lot. I have my own personal, this is Bethany crib sheet. And I wrote a crib sheet about my crib sheet so I could remember what was on it. So I have my summary of diagnosis, and I also have my summary of diagnosis that no longer apply, because there's a lot of those in my medical record, and they'll go in and pull something out from like 20 years ago, and I'm like, that doesn't apply anymore. I have the list of surgeries, because I can never remember, was that 2014, 20, whatever, I don't remember. And then I have all my current prescriptions, and I have my TPN. As one of those pages in there, because if you can get in the emergency room before 5 p.m., they can order your TPN for that night, at least in my system. Sometimes it's noon, sometimes it's 5, whatever. But I start to push that as soon as I walk in the door. And then I have a paragraph about my values and things that matter to me. And in that I'll put, when I was trying to be able to do the half marathons, then I put that in there. Working full time was one of those things on mine for a very long time when I could not do that. And then the last 2 pages are contacts. So it's the directory of my team, which is like 25 people right now, and it has all of their names, the institutions that they're with, what time zone that's on. That sounds funny, but you do need that. And then the best way to get a hold of them, and then my emergency and family contacts, because sometimes they're not with me, or or whatnot. But I take that with me to make sure that and then I make sure that they do something with it. Because like they said earlier, you could have the plan of care and then they could just like throw it in the trash. So I'm like following up with the nurse, like, did you do that? Did you put my TPN in? Did you call my PCP yet? You know, whatever. And like you said, quarterbacking the team and just making sure that that's useful.
And Dave, do you have something similar, or how do you prepare for a visit when you're going to go and meet a provider?
Well, pretty much every physician that you go to, right, they want you to have your list of medications and your list of surgeries. And so having a current list and having an existing, the existing paperwork within your folder at home, you know, keeps you up to date. But one of the things that I also keep in my wallet at all times is the information that's on my central line. It's super important that if you go in for an emergency situation or if you run into ER, if you have a line infection or whatever, it needs to be changed out, they have to have the correct information on the type of device that you have implanted. So that's super important, just keep all that stuff on hand. And probably copies within, you know, your glove box in your car, and, you know, places that you can easily grab and go.
So I'm in a small program compared to Dr. Adams' program. We have about 25 to 30 home TPN patients. We actually keep an abstract version of their entire course that if in Little Rhode Island, they're not traveling very far for community care if they need it, or back to our institution, which is siloed, like others may experience in their own network. So we have a summary of all of what you mentioned, a summary of the medical course, you know, the anatomy of the short bowel, every central line, date and type of line, and if it was removed, reason why. So we have an abstracted version that we, as the clinicians, can easily provide to the ER to prep them if somebody's coming in, or if we're making a referral to another specialist. A lot of the electronic medical record systems now, many of you know, you might have your My Chart, allow you to also tell your story. And so many of our patients have written up kind of their personal story, not necessarily the medical history part, but a lot of their goals and expectations and, you know, kind of the stuff that takes a long time when you go into the office visit, if you don't want to start from birth all the way up to this time, that it's right there for people to actually read and understand more. And it's a conversation starter. And we also have a section in a notes section right on the face page, if you can imagine, of the electronic medical record, that we are the team that manages this patient, that they need large amount of fluids, even if the TPN can't, not enough time to have it compounded, how to get in touch with us if we're not aware of the admission or whatever. So lots of systems in place for that. Dr. Adams, do you have something similar or recommendations?
Similar to our patients as well. We keep an active problem list through the electronic medical record, and we do something every month. We pick X amount of patients that we are chronic patients, and we review and we go through. Why are they on TPN? You know, can we get them off TPN? What's their line issues? And so we keep that chart updated so that, you know, within the year, hopefully all of our patients are getting renewed and discussed. And of course, anytime we see them in clinic or unfortunately in the hospital, we do keep that active as well.
Okay, can you also talk a little bit about some shared decision making with your patients?
Yeah, I think this disease requires a lot of shared decision making, because so much of this disease is not just to take care and make sure we're doing the right formula, but how do we let people live a good quality of life, right? And so for some people, you know, that might be, I just want to do whatever I can to get off PN for one night so I can have one night of freedom. For some people, I don't care, the PN's easy, I need you to help me with my diarrhea, right? And so I think outlining with the patient, what are the things we can do to help improve your quality of life, knowing that we have limitations. And we'll try different things and we'll discuss, is this working, is this not working? There's some newer medications out for short bowel that you may or may not be aware of, and we'll try those in our patients sometimes. And if they're working, that's great, and if they're not, we'll stop it. If we try a different formula or a different plan with fluid administration. So I think it's all about feedback and making sure that you have a good relationship with your provider and or the healthcare team so that we're on the same page of where we're trying to get.
Dave, you've said a couple of times that your medical condition doesn't define who you are. And so how do you share that type of belief and your own goals and expectations when you're visiting your healthcare clinician or seeing an expert referral?
In addition to the education that you need to gain yourself, I think you need to project to your physician and your team as far as what your goals and aspirations are. I knew that I did not want to be on disability or have any limitations. This is a limiting situation. You know that and you educate yourself, but I knew that I wanted to, again, stay active, and I told them as much. If you can help me maintain full-time employment, be active in sports the best I can, set goals to run a half marathon, express those things don't be limited, express those to your medical team, and with good communication, they can help you get there. I think if you limit yourself, that could kind of have a little bit more circumstances as far as your emotional health too. I think if you move forward and accomplish things, it's much more empowering to you, and I think being empowering and being in an emotional state in a positive way will only help you maintain your overall health better.
Mm-hmm. Bethany?
Yeah, I think one thing to note, I'm just thinking as we're sitting here, we've come a long way, and it took a lot to get here. If I would have been sitting up here a year ago or 2 years ago, it would have been a different story, let alone 5 years ago or 7 years ago. And so it is step by step. I never thought in a million years this is where I would end up. There were days when I was just hoping to get out of bed or wanted to shower by myself, things like that, go to the bathroom without someone there. So, I think just remembering that it is tiny steps to get you where you want to go, and you may not even have any idea where you're going to go. I always hated it at work and the reviews when they're like, where do you want to be in 5 years? And I'm like, alive. What do you want from me? And so, knowing that you probably don't know where you're going to be in 5 years, and that's okay. And it'll be up and it'll be down. I'm here now. Who knows how we'll be at the Oley conference next year. So I just think acknowledging that roller coaster ride. I don't want to sit up here and project like life is roses. It's a series of setbacks, and you have really good times, and you have really crappy times, and everything in between. So, and that's okay.
Mm-hmm. Mm-hmm. Dr. Adams, how would a patient find you? If somebody wanted to come see you or have the expert consultation with your team, is that possible?
Yes. I think a large problem with patients suffering from intestinal failure, though, is figuring out where the expert places are. Once you figure out where it is, and hopefully if your insurance will cover it, you just call and make an appointment and we would see you. But I think the logistics of identifying where the closest center of excellence is and then finding the resources to get there. I say this multiple times, but in an ideal world, our insurance companies would acknowledge that there are isolated centers of excellence, and our patients would get better care if they would help people get to those places and get the care that they need. I think there's a lot of room for improvement in this with advancements in telehealth, and it might really expand the care you are able to receive, maybe not, right outside your door. And so, as physicians, we're really promoting how do we get to patients in these kind of healthcare deserts, and I think telehealth is a way that we can really make that happen. But yes, most of all these centers, we're excited to see patients with intestinal failure because we think they're out there in the community and they're not being cared for appropriately. So we absolutely want to see these types of patients in our centers.
Good. Yes, please.
Just something to add to that too. You know, you don't have to go to the Center of Excellence all the time. And so I have a team locally that knows how to get in contact with the Center of Excellence if there's something that they are not comfortable or I'm not comfortable. And so you do still need your local team to support you on a daily, weekly, monthly basis, depending on what's going on. But then having that access, because I think sometimes people think I can't go to a Center of Excellence because then I always have to go to the Center of Excellence. And that's not the case. You can have a lot of things managed with them as kind of a consultation. You go see them every year, every 2 years, or whatever is the proper cadence. So it's not as tough necessarily.
When we see those patients, we'll write a letter to the primary care or the gastro, whoever's managing it, and it's very important to have local care for things like line emergencies, right? You don't want to be traveling across state for that. So absolutely, if your Center of Excellence isn't near your home, having a team close to home for those types of situations is key.
Yeah, and there's been a lot of other organized ways where feedback can be obtained for us in Rhode Island, where there is no formal intestinal transplant or intestinal rehab program. Our patients would have to go to New York, or our children would have to go to Boston or further. And strangely, Rhode Islanders won't travel even 45 minutes out of state to do that. So we'll sometimes arrange communication directly with those centers as the clinicians, doing basically colleague to colleague, what would you do in this situation? And those kind of activities can happen as well. There's a formal program. Have you, anybody here, non-clinician, heard of the LIFT echo? And if so, hands up. So no. Okay, so LIFT echo stands for Learn Intestinal Failure Therapy, and ECHO stands for Expanding Community Healthcare, I forget the O, outreach, yes. And so what this is it's education. It combines education for clinicians and case presentations, all with anonymity and HIPAA protection, but a clinician who has a challenging patient who may not be an expert in the management of short bowel syndrome or aspects of TPN or the complications associated with it, can actually present to a large international, interdisciplinary attendee audience on Zoom and give a case presentation and get feedback from experts all over. And this has been a wonderful way for people to get feedback. When we do this, we tell our patient, we're going to present you with the privacy and anonymity, and just see if there's things we haven't thought about, and maybe aspects of care that we should think about further. And so that is another opportunity to seek out expert advice and then use it to provide best practices at home. You've participated in that. Do you want to share a little bit about?
Sure, it's a great platform for any physician. You don't have to be one of us doing this. In fact, initially, it's really designed to reach out to the physicians that don't have expertise, can bring a case. So if you have a great, GI or surgeon or primary care who, is really invested and wants to present your case, they could absolutely join and get the expertise from the various clinicians that are involved in this session. It's helped to build the community of clinicians that deal with short bowel, and I think really identify that we need more, though. We're still not reaching those physicians that don't already know about short bowel, and so we're still working on ways to maybe get to the patients as well.
And as a patient, you could say to your primary care or your GI or whoever you're dealing with, would you ever consider to present my case at Lift Echo? And you just have to type in Lift Echo and the whole website comes up of how to do that. But more importantly, I want to share with you that we're really, and I'm going to share with you this on behalf of Dr. Kishore Iyer, who is known to the Oley audience from Mount Sinai in New York City, intestinal transplant and short bowel syndrome, intestinal failure expert surgeon. It was really his brainchild, this innovation for this tele-learning. And with his permission, I can tell you that we're actually exploring the possibility of doing a patient-facing echo, because currently, as a patient, you can't log on and participate in this. It is a clinician forum. But we want to evaluate the effect of tele-learning on outcomes for patients with chronic intestinal failure through this virtual forum. And the pilot study that we're proposing, that we feel fairly confident we're going to get funded for, will indirectly increase access to expert care and expert knowledge in chronic intestinal failure by focusing on best practices. So more learning and not how to manage individual personal health situations. But this should be an exciting opportunity. There are many echoes for so many projects across the world, thousands of them, and only one or two patient-facing. So this would be really a very unique program if we're able to do that. So in the next few months, we're hoping we'll be doing some small pilot programs. There will be some announcements on Oley website and through some of the other organizations, and also through some of the home infusion companies. So you may see an announcement. And the eligibility would be patients and caregivers who are not currently receiving care in an intestinal rehab program, but they are on parenteral nutrition or have chronic intestinal failure. And this would be the group where we want to host these learning opportunities to get this expert care through you to also help educate your clinicians. So we think that will be a really great opportunity. And there are other similar programs like that around. But I want to go now to some important concepts that everybody has emphasized, and that's the self-advocacy efforts. And could you share, Bethany, a little bit maybe about your self-advocacy experience, and maybe even tell us how you came to develop Transplant Unwrapped?
So I think, first of all, being my own advocate is my full-time real job. It doesn't pay, but I don't get to do any of the other things unless I do this job right. And it took a lot of me not doing that to realize that that's how it is. Get used to it. And it doesn't mean that I sometimes don't forget to do things or fill a prescription or make a phone call or whatever, but I do acknowledge this is my full-time job. And so once I did that, it was a lot less struggle for me personally. In terms of becoming involved with intestinal rehab and transplant unwrapped, well, you can probably already tell, I like to talk a lot. I love to meet people. I love to learn. Doing research, finding people who do research professionally. I'm always trying to learn and educate myself, like you mentioned. And that's what we try to do as a patient organization. I was really good friends with our founder, Kayla Fobb. And so once I got involved in the organization, I just can't help myself. And I love working with our organization and connecting people, giving them knowledge, and also just letting them know, like, you're not alone. There's a lot of people facing this across the country more than you think.
Mm-hmm. Dave?
I think knowledge is power. educating yourself as best possible on your situation and reaching out to resources as well. I think a great resource is your peers. You know, whether you meet somebody today or you've got a friendship with somebody that's dealing with the same situation that we are, you kind of build your nucleus of support there. I've been really fortunate within the Cincinnati metro area. There's about 6 of us that are TPN patients, and we get together like quarterly just to go out to dinner or meet at somebody's house and really kind of support each other and pass on information that we've learned. You know, whether we're reading something, we get information on a specific specialist or physician. I ran into a situation this past, 2 years ago. I was really fortunate when I first had my surgery that I had my surgeon take care of my TPN for 25 years. My gastroenterologist was a consistent part of my team for 25 years. And also the home health care company that I had nutritionists. They had programs on board for nutrition and you know, physical fitness to a certain point. And so I relied on all that to maintain my health to the best possible way. But 2 years ago, I had a long standing Hickman line in for 11 years. And it kind of went south on me. And I was in a situation where my gastroenterologist had retired about 1.5 years prior to that, and my surgeon retired as well. So I did not have the foresight to pull that all together until I came up into a serious situation. So I relied on the peer group that I had within the Cincinnati area and put calls out and said, hey, you know, I'm in a situation where I need to find an expert. And so, you know, they gave me great feedback. I was able to find a great vascular surgeon, found a gastroenterologist, because the person that took over from my retired gastroenterologist, he did not feel comfortable actually writing orders for TPN. So I had to go in another direction, and I found a physician through my peer group. So I think it's really important to, you know, within Oley, or if you're in a position where you have some peers within your area where you live, is to gather around and get, you know, form those friendships and pass that information on, because there are times when you're going to need it. And boy, I did. So
Yeah.
It was very helpful.
Great. And Dr. Adams, how do you empower and educate your patients? Do you have any peer groups associated with your program?
I mean, I think the peer groups are amazing, and I acknowledge the need for online support, but I also say that with a word of caution, because we do know that too much online can actually sometimes cause anxiety. I think the physical presence of meeting with people in your community, actually seeing how people live like you live, is just so amazing, and just nothing's going to compare with it. So this foundation is just really wonderful for that. Just another comment on when you mentioned like reaching out, trying to find other providers. Another place you can reach out to is your infusion companies. They may be familiar with, oh, we have this doc that does all these PN prescriptions. You know, that might be another resource. Or using foundations like Oley to search for where are the providers that we can trust and find in the area. But yeah, ditto everything they've said. I think great advice.
Well, I want to save time for the audience to participate in some questions and answers, so I want to try to summarize and wrap up some of the great things we've seen and heard. But here you see a team with the patient in the center and so many different participants along the way who may be needed as experts for help with your care. But I think some key points are that every patient is unique and different. No one team fits all. Needs change as children grow, as adults age, and with new health and life events. Expertise is important. You have to ask for referrals and second opinions if you feel you're not getting a response to issues that are very important to you. You have to prepare for your visits and really be able to let your providers know that you have specific things you want to address during that encounter and include your shared values and goals. You have choice. Self-advocacy is important, and we can't understate the importance of finding others who have similar experiences and all of those wonderful resources. And we want to go to questions and answers, but before we do that, I just want to let you know that there are some really good resources for you in the back of the room. You may have seen the Short Bowel Syndrome Community Guide, and there's a barcode there you can scan, and that can provide important information for you. But at this point, I think we'll conclude and go to questions. Thank you. Hold on. They're going to come around with a microphone.
I have two questions for David. First, I'd like to know how many central lines you've had over the 30 years, and what was your longest number of years that you had one line. And you spoke about how you found a group of people that you meet with on a regular basis. How did you find them?
I'll answer your second question first. As far as the group of people, the home health care company that used to provide my TPN, I was a patient advocate for them. And you know, they were concentrated, or one of their offices were located in the Cincinnati area. And so when I was an advocate, I met a few of the particular patients and hit it off immediately. And so I think either through your home health care company, I think that there's an option and an opportunity to find out some other fellow consumers. And then certainly the Oley Foundation, I mean, they've got a roster that they probably could share with you as far as location or geography. And, you know, and I know there's other people that are out in more rural areas or whatever, and I think that's why you would reach out to just say Oley. But you know, ask questions, just be inquisitive and find out who's more local. And I'll tell you that the group that we have, the 6 of us, we kind of feed off each other. You know, it's one of those things where it's a positive feedback, and it's one of those things where we feel empowered when we get together. And I can't stress that enough, how important that is, you know. And as far as how many lines I've had, I've been really fortunate over the years. The first emergency surgery, I woke up and I had a Hickman. And so that was a frightening experience to begin with. Just, you know, having a home health care nurse come over the house, and I'm just out of the hospital, I'm, you know, just had a life-changing experience. And he's explaining to my wife, he's explaining to my parents and my wife's parents, who all came down to kind of support me in my recovery. And you know, it was overwhelming at first, but then I learned how to take care of my line myself. And the longest Hickman line I've had I've had one for 9 years, and I've had one for 11 years. And the mentality I have, even for 30 years, is every single day I treat that line as though it's the very first day I've got it. Otherwise, you kind of can get complacent at times, and you might, you know, miss out on some protocol that you need to take care of, as far as, you know, making sure that everything is you know, clean and sterile situation when you infuse, because boy, this line is directly to every organ in our body. And so I think if you don't treat it that way, even when you go to a medical facility, if you see somebody that's not treating your line correctly or is not handling it in a sterile technique, tell them right away. You say, you know what, I respect you, but you know, I've done this longer than you have. And I've been known to just kind of, and then do it in a respectful way, but you know, I'll just say, let me take care of that kind of a thing. But so I had a port at one time, and the reason that was after my first Hickman. I said, hey doc, you know, can you put a port in so I can access it, because I want to go swimming with my daughter, who was 6 years old at the time. And you know, so I had a port in, but the problem with my port was it actually festered bacteria, and I got issues with that and infections right away. So I said, you know what, yank that thing out, give me another Hickman, and it was very easy for me to take care of. So.
I'd just add to your question about how do you find others, aside from coming to a meeting like this and making some friends. We sometimes ask some of our patients, would you be willing to speak with somebody who's either newly starting on TPN or newly diagnosed with this condition? And we've had others meet up that way or meet in the waiting room in the office, or sometimes we've even tried to organize a little community event or something. So I think there are multiple ways to, I'd even ask, are there anybody else in my age category who maybe would like to speak with me or something, and that kind of starts it percolating. But that might be helpful too. Other questions?
Thank you very much. I thought this was very informative and an excellent presentation. I just had a comment. I'm a support group leader. I started the only ostomy and feeding support group in the country. And I live about 2 miles from Cleveland Clinic in Florida. So I get many calls from people that recently got ostomies or recently got put on TPN. And many of them, what happens is that they come out of the hospital and the doctors are very proud of their work because they got the person functioning again. I mean, they came in broken. They couldn't defecate or they weren't eating, and now that their body is being nourished and now they're defecating. So the doctors are working like engineers and they did their job and they're very proud of the job that they did. And they did do a good job. However, the person realizes that they're functioning, but they're not functioning the way they did before. And from a psychological, emotional, and social perspective, they're shocked. They're shocked, and it takes them a long time if they ever adjust to their new body image. And many of them come home extremely depressed. And I seem to be taking a lot of Cleveland Clinic patients out to lunch.
That's wonderful.
To try to show them that they can still have meaningful and productive lives, and that they need to make goals for themselves and decide what things make them happy and start to do those things. And that today really, truly is the first day of the rest of their lives. And I invite them to I have an international virtual support group, and I invite all of you. I'll give you my information if you'd like, and you can invite your patients and your colleagues to come on as well. And I do also have a local in-person support group that meets. And I also travel the world with all my stuff. And I do have an ileostomy, a gastrostomy. I catheterize 6 times a day, and I'm on TPN. So I'm the bionic woman and the queen of shit.
Thank you for sharing your story. That was really very important.
So my question is I'm also on the National Board of Directors of the United Ostomy Associations of America. And what we want to do is we want to encourage the physicians to take more of a part in when the patients leave their office, to be a little bit happy about the work that they just did and about continuing life. And many times the physicians are just throwing them out. Now, I don't mean saying throwing them out. The physicians are proud of the work they did, and they did do good work. I'm not saying that they didn't. But they're pushing them out to the ostomy nurse or to the psychologist. And many times, if it's not the right psychologist, and the psychologist has not lived with an ostomy or with feeding, they don't really understand what it is like. What it's like to wake up in the morning and everything, and you're covered in everything. Or to be out in public and everything ruptures and you're a mess and it's humiliating. They don't have any idea of those situations. And it's so important to refer them to support groups. It's crucial, it's critical. How can we encourage physicians to move these patients forward, that this is a critical part in the recovery? It's not just fixing them through an engineering perspective. Do you have suggestions?
I mean, that's a general concept that needs to happen in all of healthcare. In terms of intestinal failure, I think we're still fighting to get people to recognize intestinal failure. I absolutely 100% agree with everything you're saying, and it is extremely important. And I think part of the recognition and education on what is intestinal failure should also include getting people to these types of support groups and resources that you're mentioning. It's a very large problem, and I fully support any ideas and suggestions for that.
Yeah, I have done some work in the past about, trying to understand the value of support groups. We surveyed or interviewed individuals who were members of Oley to find out what was it that drew them in, and it was education and advocacy and finding others just like me and the resources and being able to act as the patient to educate the nurses and the clinicians and people they encounter. But the thing I always struggle with is how best to describe it, because the word support sometimes is, people interpret that differently, and sometimes there's a hands up and they say, oh, I don't need support. I think their connotation is it's a psychiatric or psychological thing. And so I always try to think about how best and when is the right time to introduce it. And for me personally, thinking about this all these years, I wait for the patient to have some clues. Sometimes it's immediately, like I share all the resources I know. And other times I kind of spoon feed it when I hear them bring something up or they say something. So I think an organization like yours, to have it linked to the website, to have it linked to the other TPN type of things, to display so we can educate other clinicians that it exists, that would help spread the word. It's really important, and I can't wait to go and look up your group. Yeah. We have time for one more?
So I actually have a follow-up to that. Hi, so I'm Sivan Kinberg, a pediatric gastroenterologist at Columbia University in New York. And I think what you were just saying, that physicians are pushing you out, is not because they're pushing you out. And I will be the first to admit, as a gastroenterologist, I have no clue how to manage ostomies. I don't know how to connect TPN. These are things that I should know. I manage patients. And I realized this, that the light bulb went off last week. One of my patients needed to learn how to connect TPN. The mom was hospitalized, the dad had no idea how to do it, and we had somebody do the training in the office. And that's when I realized, after doing this for a decade, I myself don't actually know how to do this. And I think that's what we have to realize, and that's where the education needs to be. We don't have ostomy outpatient support nurses for our pediatric patients. So it means that I need to know how to do this, and that's something that I think we really need to work on. And first of all, acknowledge that we as clinicians don't know all of this, and we need to learn from you, because you're the one that's doing this every day. So you need to educate us.
Yeah.
I would love to.
Thank you for sharing.
Thank you so much. Thank you, Dr. Dawn Adams, David Vermette. Thank you, Bethany Johnson and Dr. Marion Winkler for moderating. I appreciated the kind reminder about the importance of creating your own care plan. We heard that this morning, and we heard it repeated here. Everybody sharing their stories and also sharing about Lift Echo was very interesting and helpful. Thank you again to our sponsors, Ironwood. And I wanted to also remind you, we have our fun fashion show this evening in this room at 6:30 p.m. So please enjoy the rest of the conference and come back at 6:30.
Thank you. Perfect.